How do they get healthcare in the region? In Chile, there is an active intercultural health component, which means that they incorporate ethnic and cultural, in some cases spiritual aspects of this alternative belief system, and they consider it as part of care delivery. What this takes the form of in Araucanía is there are actually some health centers that are specifically set aside for Machi, which are Mapuche shaman, and which are kind of the herbalist and doctor. Or in some cases, you even just have somebody who's an intercultural health facilitator. They're ethnically Mapuche, and what they are is they have an office in a community health clinic, and they can be called by clinicians and patients to come help facilitate this interaction between kind of the biomedical Western belief and the Mapuche kind of idea. And whether that be in translation or in just orientation can be an option. There is, however, barriers and disagreements onto like what intercultural means. So some of those I'll come up with more. So some of my methods were, again, still using mixed methods, which I was trying to do back then. I did qualitative interviews, both individual and group interviews, and focus groups with mental health professionals, these intercultural health facilitators, which I just mentioned, Mapuche health leaders and healers, and I also did a small quantitative data analysis component, which got my hands on a regional hospital data set, which we'll take a look at. To give you an idea of who I was interviewing, the first thing that we did when I got there, trying to orient myself in what was actually going on in clinics, was we had a workshop. A workshop, we basically invited people, we fed them mate and coffee and snacks, and we had a conversation about what does intercultural mental health look like now. Who participated in this was the 15 intercultural health facilitators. There was 12 Mapuche health professionals, so these are people who aren't facilitators specifically, but work with the program PROMAP, Programa de Salud Mapuche. This is everyone from the director of one of the services came to people who help facilitators in the clinic. And then there were also 9 mental health professionals. Originally we intended it to be just the program PROMAP, the Mapuche health program, and word of mouth got around and you just had psychologists showing up, so it became interdisciplinary, which worked out well for us actually. And then interviews, which is going to be more of the focus of kind of the data I'm going to present today. We're 2 psychologists, 3 social workers, 1 psychiatrist, as individual interviews, and then 7 multidisciplinary teams. Most of these were biomedical teams in the sense that they were some combination of these 3 professions, or general practitioner as well. One team itself, which was a really interesting interview, was a psychologist, a doctor, and the intercultural health facilitator, which was the only time I had kind of this cross-cultural dynamic in an interview, and it led to some interesting results. I also interviewed 3 intercultural health facilitators, 2 Mapuche health professionals, 1 Tuxefe, which I mentioned is kind of the herbalist, and 1 Machi, who is the shaman. And what did I find? So, for all the quantitative people in the room, take this with a grain of salt. Everyone else, this is great. We started off with trying to take this quantitative component on Mapuche mental health, and this is kind of quick and dirty results. One of the things you'll notice is it's missing significance, so again, take it with a grain of salt. And this is only from hospitals. This isn't from kind of community clinics or rural posts, and so there's a skew on who was represented in the data. But with those things in mind, something that I want to note. In the blue is Mapuche, the people who identify as ethnically Mapuche, and the red are people who identify as non-Mapuche. And in the case of certain conditions, like alcohol-related disorders, you have a really large disparity in the rates of people who are going into or out of hospitals and being treated for alcohol-related disorders. And this is per 10,000 people. So actually, there was like more people than 63.8 people. But you get kind of an interesting inverse with some more psychiatric or psychotic illnesses, things like bipolar disorder or personality disorder as well. You kind of get this inverse where you have a lot higher rate in non-Mapuche people. And that's just something that comes out qualitatively as well. Things like depression, schizophrenia, again, kind of going back and forth. But this hints at that there are either real disparities or there are disparities in how the biomedical health system is approaching their patients. So something is not lining up here. to get at some of the data again, going back to the qualitative data, I want to get at the second objective first to contextualize the first objective, and this is something that we realized we had to do. We did in the reverse, we did 1 and then 2, but 2 actually helped you form 1. So we're going to explore kind of the concepts of mental illness. So what mental health problems are the most common in Mapuche patients? Yeah, so one of the things that the social worker in Sevejo said is there's a lot of alcoholism, but because it's invisibilized, people don't ask for help. This idea of invisibilization of kind of these psychosocial problems like alcohol abuse came up a number of times. And interestingly, they were often pegged as quote-unquote cultural problems of the Mapuche. They're tying culture to this psychological problem, despite the fact that alcohol actually didn't really exist in the society before it was brought over to them. So one of the quotes was, the naturalization of alcohol consumption, domestic abuse, rape, including of minors. These are things that show up a lot in kind of when they're working with Mapuche patients. The Community program, I'll talk about in a little bit. But there's a difference in also these more psychological and psychiatric disorders as well. The differences in how people understand depression and psychosis. One person said, the Mapuche suffer less depression, that for them it's different. People said that, for example, Mapuche don't get schizophrenia. And so you have, again, this discordance between what people are being diagnosed with, because you saw that Mapuche people are being diagnosed with schizophrenia, but what is actually happening or what people's beliefs are. And so there's some discordance, again, in some of these understandings of what is the illness. And then finally, one of the things that's coherent with cosmovision is this idea that there are spiritual and environmental determinants that are unique to Mapuche patients. Someone mentioned this idea of the poverty of the soul. We were talking about economic poverty, and they're like, well, it's not just economic for us, it's a poverty of the soul. People talk about spiritual calls to be machi or lonko, and when they have these dreams and visions that call them to be these traditional figures that are kind of spiritually called, people tend to think of them as schizophrenia. And so that was a difference that got mentioned a lot, as well as transgressions of places and spirits. That a person transgresses kind of a sacred site, or even a site in general, and that can cause what we considered mental health problems. So looking at some of those problems, we wanted to take an understanding of what is the concept of mental health from a Mapuche perspective. And I had some relatively frank responses. Mental health is such a small thing that in the end, it's silly to have an investigation just about mental health. My apologies for what I'm telling you. The person has 4 things at a minimum: spirit, mind, emotions, and body. So very tactfully, he basically told me that my investigation was crap. But brings up a really interesting point, and something that I knew going into this was this idea of there is a discordance in what people understand about Mapuche mental health, that it's not the same as the Western mind-body duality that we tend to set up, or at least biomedical health system set up. Interestingly, one of the psychologists echoed something else that was shared, was the diagnosis might be the same, but the origin and variables are different. So while someone might have, quote unquote, a depression, or they might have anxiety, that where that comes from might be spiritually based. That the roots of that might not just be in biology, or might just be in a social situation. They might have a spiritual disequilibrium. And the same with variables, where there are variables that exist for ethnic Mapuche people who, well, again, might be different. All of this kind of reaffirms this idea of cosmovision of what are the components: the body and the family, the community, the environment, social norms and rights, religious life and spirituality. There is a context around mental health that can lead to either well-being, if it's a healthy balance, or futran, which is disequilibrium, which is illness, is really like to think of it. So with that in mind, that there is some difference in how patients tend to conceptualize their mental health, I want to talk about what is happening in clinics. What are people doing for Mapuche patients? The first one that I asked was, what activities do you carry out for Mapuche patients? And the general response was that biomedical professionals are doing biomedical practice. They come to the hospital usually wanting Western medicine. You know who my principal rival is? The doctor. Patients want pills over psychology. This is relatively shared across a lot of the clinicians. But there are a couple special programs, one of which is the Community program, that take a slightly different approach to working with Mapuche patients. One of them takes reflection workshops where they incorporate traditional leaders as well as kind of institutional actors like the police to reflect on what is the state of mental health in a community. And the community program, I'm just going to read this one. The community plan de unir tune through neutral, which is a type of participatory psychology without alcohol, without violence. To unpack this a little bit, what this means is that the community program is using neutral, which is a type of kind of indigenous methodology, participatory psychology where you discuss, you converse. They bring together a psychologist who speaks Mapudungun, which is the traditional native language, Kimche, which is an elder, a knowledgeable person, and chronic alcohol abusers. These are usually elderly people who've been consuming for decades. And they reform kind of these quote-unquote traditional social ties. They have conversations, extended conversations over time. They're rebuilding what is can be considered a Mapuche relationship with this person who's been disconnected for a long time. And when they did this in one community, these elders, without prompting from this team itself, this wasn't the team's plan originally, these elders basically came together and realized, like, you know what, our community is sick. And they raised a Niyatun, which is a community prayer ceremony. It's typically a very powerful, very empowering thing for communities. It's something that hadn't happened, they said, in the community for a number of decades. So there are some kind of gems hidden in mental health services in the region. How does your clinic adapt its attention to incorporate mental health treatment? So with these biomedical health professionals, what are they doing for their Mapuche mental health patients to make it more intercultural? One said that I'm a validator. I accept and facilitate perhaps, but I don't give it myself. The interculturality, the Mapuche aspect. Again, echoing this fact that they're biomedical health professionals doing biomedical practice. Instead, most of them talked about the intercultural health facilitator. I mentioned that this is the Mapuche person who helps facilitate biomedical belief for their patients. They have what we lack, knowledge of culture and language. And despite this kind of general model of how intercultural mental health is enacted in the region, there was a lot of heterogeneity. Depending on geography, depending on what resources were available in the clinic and the municipality for Mapuche mental health, that differed greatly. In the case of Puerto Saavedra, which is a seaside town, they have a hospital, and right beside it is a building, and it's designated for Mapuche health practice. They have Machi, who come 5 days a week. They have Loncos who come, who are kind of like the chief who come. And in this case, the psychologist talks about, we try to meet with the Machi and the Mapuche health unit for some cases that require more intervention from both sides. Here you get a really good idea that they're working together. In others, from Karawe, they say, I don't communicate much with the facilitator. It's a tool we have not used very much. And the team in Koipui goes even further to say, we don't differentiate. We treat everyone the same, Mapuche or no. They all have the same access. The difficulty is more with rurality. And so for them, they go as far as kind of denying the fact that despite 8 or 9 out of 10 people who sit in front of them are Mapuche, that there is no difference. And there might not be. We're going to explore that one in a second. So what are the challenges to intercultural mental health? Like the US, there's a large problem with burnout. It's very burdened systems. The doctor mentions that they're classed treating a patient every 12 minutes. And you go to some of the clinics and realize that that's probably very true. There's also a lack of interest or respect. It kind of hints at this deeper problem of clinicians themselves, which is the fact that they have ideological differences that might not respect or believe in, mainly respect, or be interested in this idea of Mapuche mental health. And someone mentioned that these are things that are never going to change. There are also many types of Mapuche. This is something that the facilitator mentioned, and what she's getting at is this idea that now you have Mapuche who believe in cosmovision, you have Mapuche who don't believe in cosmovision, you have Mapuche who are evangelical and religious and Christian, you have Mapuche who are atheist. And they live in the city, in the country, in Santiago. And so she can't go into a clinical encounter with a Mapuche patient and assume what is one Mapuche person. Finally, there's differences in systems. It's like mixing apples and pears. And how should we address this? So people talk about this idea of needing openness. They talk about the idea of letting patients guide what does this mean, being a very patient-centered system. They talk about greater linkages with intercultural health facilitators and traditional healers. They talk about greater community-centered work, that the clinicians should be part of the landscape. They're talking about psychologists and social workers here, that they should be really integrated with their community. And finally, going back to the community program, using Mapuche methodologies, in some cases when it's appropriate, to situate yourself in the Mapuche world. How does one achieve this? By recognizing the other. In this case, their science, their knowledge. It breaks a historical cycle of domination. And in order to kind of get to this point of what is an intercultural mental health treatment, what do they need? What do these teams need to have? Pretty much everyone echoed a basic understanding of cosmovision, of the language Maputungun, of history, that helps to contextualize when they're working with Mapuche patients. And not necessarily assume that they're working with cosmovision, but a patient who believes in cosmovision, but instead to be able to ascertain whether that would be a factor. They also need respect. That was something that a lot of people mentioned was lacking, is from clinicians who come, that professionals don't come with this orientation to be open to Mapuche medicine. It's something that has to be kind of developed over time. Concrete tools and resources. I had a psychologist get really passionate and said that it makes me so mad to hear a training talking about the history of interculturality. Why don't they do us intercultural clinical cases? So why aren't they giving us things that we can use as clinicians that actually would allow us to do better practice? And finally, university level training, so teaching courses as well. To conclude rapidly, because I'm out of time, the conclusions and future directions. So going back to what is the idea of Mapuche mental illness, or Mapuche mental health, excuse me. It is slightly different. It incorporates spiritual and environmental factors or determinants. But that being said, there's a lot of heterogeneity in what is Mapuche identity these days. Chile determines it by last name. So if you have one or two Mapuche last names, you're considered ethnically Mapuche. However, again, some of the things that I've talked about is that's a very complicated reality in today, given that there's a lot of hybridization between these two different belief systems. Furthermore, there's a lot of heterogeneity in what resources and staff exist in these clinics, and so making a standardized intercultural health program is aspirational, and there are some things that our research team is hoping to kind of do to advance that, but at the moment it's a little ways off. But first, some things that clinicians can do now would be to consult patient preferences, form links to facilitators and healers. These are things that they can do existing with what's in their clinic. They can also, at some point, education and training to develop respectful and structurally aware understanding of both systems, meaning that they can contextualize themselves in what is the reality in the region. And finally, something that I've wanted to add is this idea of there's a discordance between biomedical and Mapuche health beliefs, and this manifests in the way that the health system has created intercultural health. So I'm happy to discuss this in question and answer if there's time, but the idea of intercultural mental health within the system is likely to be very complicated. Where am I going from here? Obviously, we're at the point where this is a lot of quick and dirty data. We want to analyze the data better. We want to return it to the clinicians, to the communities, to the leaders who've all worked with us, who've been very giving in their time. And we're hoping to design a training program or some sort of structure or protocol. I'm also interested in this idea of Mapuche mental health in the context of violence, trauma, and colonization. It's not something that came up within a lot of the biomedical health professionals, but it was something that came up a lot of in healers, and they talked a lot about the history and context. And so that would be an interesting thread to pull a little bit more. Obviously, something that was lacking from this that I would hope a lot more for was this idea of patient and community participation, which is something that takes a lot of time. And finally, going back to this idea of for its objective is to continue promoting mutual understanding among nations through engagement in the host community. As I mentioned, I would meet with psychologists who work with 80 or 90% of their patient population with Mapuche, and I would ask them, I'd prompt them about what do they do for their Mapuche patients. And that was the first time that they'd ever thought of it. And so, in a very, very small way, I hope that at least trying to start this endeavor would be something that could help advance the idea of mutual understanding. Thank you to all of these wonderful people, including my parents who are here.
We do have time for questions if you want to take them.
Cool, yeah. I don't have any questions.
If there are any questions, yes. In the meantime, I'm going to see if I can fix this. I did have a question, actually, if you don't mind.
Yeah.
So the incidents of, what were the names for the shamans that you mentioned?
Machi.
The Mati, so they had a very central role in the community in the Mapuche region, did you say?
Yeah, so they are, they're traditional figures. They're typically very powerful in the community. They're kind of, they're a healing figure, and they're in a lot of ways, they are kind of the person who communes with the spiritual world. And so, in a cosmovision that places a great deal of importance on spirituality, having this figure who basically forms a link between you and the spiritual world is fundamental. At the moment, the way that the healthcare system uses them is not exactly the best. And this is one of the things that came out, was this idea that machi have to be connected to the rewe, which is essentially it's the site where they became machi. It's their place. Like, they gotta be there to really do a lot of this communing. And the way the intercultural health system has set them up, and this is a big complaint, is that these machi have to go to clinics far away from where they're powerful, and treat people. And so they can only do so much. They can only do basic diagnostics, they can do controls, but they can't really do their purpose within kind of the Mapuche medical system. And so that's one of the main discordants that people talked about. But yeah, so they tend to be pretty important.
Thank you.
Yeah.
I'll probably ask you more questions on that later.
Yeah.
Anyone else?
Oh, I'm interested, did they, like, translate any of the materials? Like, was there problems with, like, Mapuche coming into the hospital and not even understanding the materials in total? Or, like, did they have, like, a translator on site? Because I know that I would assume that there are some people that don't speak Spanish.
Yeah.
And that are extremely immersed in, like, the Mapuche community.
Yeah, so the intercultural health facilitator is actually key in this sense.
Okay, so they serve as
are
translators as well.
all speakers. They're all biomedicals. Actually, surprisingly, and one of the psychologists who's working in a very intercultural hospital talked about that his issue is not so much with language, that unless you have somebody who's like 80 or 90 coming in, who are monolingual Mapuche speakers, typically it's not the language. It's more of the concept of psychotherapy, like Western psychotherapy. That they come into the clinic, and Western psychotherapy is very much like, here's something that happened to you. Like, what do you think? Like, what is this? How does this affect your individual? And for them, it's decontextualized because it's not necessarily an individualistic understanding of self. And in some ways, they're not. The way that they express themselves is not one where this is how it affected me. They talk about how this is the effect it has on, like, my family, my community, or they get themselves kind of through that. They have a different way of kind of addressing and we consider kind of therapy. For example, one of the things that came up was talking about grief, and so psychologists tend to work through grief. They tend to bring it up, and for Mapuche, they don't want to bring up a grief again. It kind of just keeps it alive for them. They haven't. What they want to do is relive kind of the good experiences of a loved one who died, and that's how they tend to get over it.
Did you encounter, like, any problems with comprehension? I don't know, at least like in the part of mental health that I've been working in, a lot of the people complain that they don't necessarily understand what happens when they go to the doctor or what the doctor says to them. Even if they were going through a translator, they could be speaking the same language, but that because of the time that they take with them, it doesn't give them adequate support in the sense of, like, comprehension.
Yeah.
And, like, especially, like, informed consent for, like...
Oh, yeah.
Like,
that's
huge. I think that's probably, like, another topic, but I wasn't sure if it was something that you encountered.
No, comprehension is definitely a big thing. I'm just going to speculate here that one of the things that came up was there's a really high dropout rate. Like, it's a very, very high dropout rate. And so people come to 1-2 clinics and then they just never come back. And, from the health system perspective, I see that as an opportunity to kind of pull them into giving better practice, because for them it's very numbers driven. They see dropout, they see a low dropout rate, and they're like, this looks bad. And unfortunately, that's something that motivates the health system, both here in the US. But, so for them, giving them this idea that, like, this is probably because your patients are really disconnected from the person that they're sitting across, in a lot of ways. But I think there's definitely a comprehension issue to be said.
So
Last one. Yeah.
Sure. You were saying you could mention just a little more about how, do you think interculturality is not going to be able to be within the system? Like, is that not, or what is your thought about that more deeply?
Yeah, so something that come up a lot, I've been kind of pursuing on the side is taking a more anthropological look at a lot of this. And the Kumu program is a really good example. So in Saavedra, which is where I worked for 3 years, they had the mayor. So the mayors are essentially in charge of the municipality and the financing for including who gets what positions, what roles. So they put somebody in place who was able to really advance this program. 3 years later, when this program, or excuse me, it wasn't even a program, it was a project. That's the thing is some of the really good ones are projects, which are non-permanent. When the mayor changed, they cut the program. And so you're building all of these ties with the community through a psychologist, through a kimchi, and they're cut. And so all the advances in 3 years, they don't know what happened. And this is very consistent story that they're cutting these really good programs, that they're cutting a lot of the projects. Beyond that, the project, when it was moved to Galvarino, which is another community, is now having problems getting financed by the government. They're like, well, we're going to finance you, but they haven't given any money. And so they have kind of these tricks from the health system to not really advance some of these things. And so it's a health system that says that they're really open to this idea, but it might not be the idea that the intercultural mental health that they're really looking for. So.
All right, so one more round of applause, please, for Randy.